Very good. So, good afternoon. Thank you for joining this webinar, Current Opportunities in Teledentistry. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health. This webinar is part of the Missouri Coalition for Oral Health lecture series. The lecture series features topics on areas that support our mission. Our mission as a nonprofit is dedicated to improving the oral health of all Missourians through sound public policy and public awareness. We have been fortunate to achieve a number of successes in recent years, including establishment of the Legislative Oral Health Caucus in Missouri, filling the state dental director position, and the reinstatement of Medicaid adult dental coverage, a policy change that has increased access to dental care for 350,000 Missouri adults, and to date has resulted in the delivery of $50 million in dental services to this population, while simultaneously decreasing the use of Missouri emergency rooms for untreated dental conditions by a whopping 44%. Rare successes in policy. I want to note real quickly, the coalition is funded by the Health Forward Foundation, the DentaQuest Partnership, and the Office of Dental Health at the Missouri Department of Health and Senior Services. The coalition has worked to promote the development of teledentistry for several years, starting with sponsoring Dr. Paul Glassman at our 2015 Oral Health Policy Conference to talk about the development of teledentistry in the state of California. This led to extensive discussions about development in Missouri. Through our collaborative partnerships, Missouri policy has been changed to make teledentistry happen in Missouri. We are especially thankful for the work of the Missouri Dental Association, the Missouri Dental Hygienist Association, and the Dental Board and the legislature.
All right.
Teledentistry will transform access to care in Missouri where it is most needed, including rural areas and for people who have the greatest difficulty getting health and dental care, including people with disabilities, people who are elderly, and families with limited income. Much work still needs to be done, but we have started a development of a new system of services and supports. In Missouri, Dr. Suter continues to be on the cutting edge. He is the Coalition Board Vice Chair and the Chair of our Conference Committee. He was the Oral Health Director and a practicing dentist at Country Comprehensive Health Center, a federally qualified health center, or FQHC, in Festus from 2013 to 2018. He was instrumental in starting the dental program at a fast-growing network of FQHC dental clinics in Jefferson County, Missouri. He is now the Oral Health Program Specialist at Comtree, overseeing the teledentistry program, grant writing, strategic planning, and business analytics. In 2017, Dr. Suter purchased a rural private practice in House Springs, Missouri. He splits his time between Comtree and his private practice, Greenleaf Dental. In January 2019, Dr. Suter started Access Teledent, a consulting company to help health centers and dentists start using teledentistry. In November of 2016, Dr. Suter received both the National Network for Oral Health Access Outstanding Clinician Award and the American Dental Association Dr. David Whiston Leadership Award. And he has been part of the coalition since 2014. And with that, I will hand it over to Dr. Suter. Thank you very much, Dr. Suter.
Thanks, Gary. Appreciate it. Welcome, everybody. Thanks for coming to this webinar. Feel free in the chat box to leave any comments, and we'll get to your questions at the end. And so we're going to move on here. I'm going to cover a lot of content, and some things I can get into more detail. If you have a particular question, there's a broad range of people from different backgrounds and even locations. So you might be at a different place in your development of teledentistry. So with that, we're going to go on. And today's presentation is sponsored by Mouthwatch. They are a maker of cameras and treatment plan software. Disclaimer that whenever we had our first pilot program at the health center, Comtree, Septico donated 2 portable dental operatories for that. I also, like Gary said, have a consulting company, Access Teledentistry. And again, there's a comment about Mouthwatch. This is a little bit about what Gary had talked about, my background in public health and now doing private practice as well as helping in public health still.
Dr. Suter, we actually cannot see your screen share at this point.
Oh, okay.
We can see you, which is
I
fine.
think maybe I have to mute that then. Does that work?
No, you should there should be a screen share button up at the top, and I think you'll have to hit that and then select the thing you want to share.
Is it working now?
There it goes. You got it.
Perfect. Sorry about that, guys.
No problem.
Okay. You good?
Yep.
All right. This is a little bit of a backstory about the health center I worked at. I worked at Comtree and started their dental program. It's a FQHC that the dental program began when I graduated dental school. Started with just me, no dental clinics or anything like that. And last year, for our last UDS report, we ended with seeing over 9,500 unique patients, over 22,000 visits. And that was across one mobile clinic, 2 fixed clinics, 3 school-based clinics, and 3 portable teledentistry clinics with around 12 dentists, 6 hygienists, and 25 dental assistants and support staff. That's kind of my background. And then through my journey of learning about teledentistry, created this presentation today. We're going to go over current grant funding opportunities in Missouri and nationally, teledentistry definitions and terminology, teledentistry advocacy efforts that we took, examples of current dental programs, indications of how to implement teledentistry, and factors to consider when implementing a program, then also potential use cases for teledentistry in the future. So current funding opportunities. So right now there is a state of Missouri teledentistry program offered by the Department of Health and Senior Services for $94,000. They're going to award one grantee organization per year for 4 years, including funding for things like supplies and equipment, salaries to get the program off the ground. There's no restrictions on who can apply except for the fact that you have to be a Medicaid provider. Applications are due on the 10th of May, and Access Teledentistry was really created to help the state of Missouri in this HRSA grant. So we are going to be providing technical assistance for all these programs and an annual training program. The annual training program that we're planning sometime in the late summer, early fall, is a full day training with 14 modules, and these are the areas that we'll cover in the full day training, talking about just an intro to teledentistry, examples of projects around the country, Access Teledentistry's 4-phase approach to teledentistry, which includes care coordination, data collection, examination, follow-up, photography hands-on training, which is a key part of how we do teledentistry in the programs that I've started, doing hands-on teledentistry case studies and hands-on examinations, then legal regulatory overview, technology and operations, financial sustainability, training and evaluation, and then finally potential applications for teledentistry. So that's a full day training course that we're going to be offering to anyone in Missouri that wants to partake in that. Finally, this state also got a federal CDC grant for a teledentistry sealant program. This is a one award for $81,000. It has to include a sealant program, and funding can go towards educational activities. And again, must be a Medicaid provider. This opportunity should be posting it within a month, we're hoping. And again, Access Teledentistry will provide technical assistance for this as well. The last thing is the federal HRSA Oral Health Infrastructure Grant, which is a grant opportunity for HRSA 330 grantees. It's one-time funding for a max of $300,000 There's going to be a maximum of about 250 application awards, and it is focusing on integrating oral health services with special call out to telehealth and virtual dentistry in the RFP. Can go towards equipment and training and consulting and information technology. That application due date is coming up very quickly on the 22nd of April. So what is teledentistry? The ADA provides this if you look at the ADA's website, they provide this definition of teledentistry, which is a mode of patient care that essentially uses telecommunications to convey health information to a dentist that is not physically present. And I'll spare you from reading the whole thing, but they released a guideline for understanding teledentistry in 2017. That's very good information on their website. It really boils down to the fact that the same standard of care applies whether you're in person or you're using telehealth. And if you think of that for every decision you make, that is what guides your teledentistry principles whenever you're setting up your program. In Missouri, there was a definition for telehealth, which included the most common form of teledentistry, which is done with what's called asynchronous store and forward. And this is right out of our bill. And you got to think of telehealth and teledentistry not as a new procedure, even though there is a code for it. It's really just a new way of accomplishing the same results that you were doing physically. And always remembering to keep that standard of care the same. We're going to go through some important terms. So your state by state, the legal definition may vary, but there's two distinct kind of terms here, which are the originating site, which is the location of the patient, and the distant site, which is the location of the dentist at the time whenever this is all getting done. And so it's important to note this. Most states require you to document something about the originating site in both notes by the person collecting the data of the patient and then the doctor that's doing the examination. Also, there's the two very important terminologies here, synchronous and asynchronous. So when most people think of telehealth or teledentistry, they immediately think of like a Skype communication, a Skype type or FaceTime type of communication with the patient that you traditionally have thought of maybe whenever you hear of telehealth. So that is called live simultaneous communication between the patient and the doctor, okay? And usually with a healthcare provider facilitating the appointment, okay, on the patient's end. That is called a synchronous communication, all right? And the ADA actually added an ADA code in the adjunctive category called D9995, synchronous teledentistry, okay? The next terminology, which is the most common use of teledentistry when you look at things like the virtual dental home in California and other states, is asynchronous. This is also common in dermatology. So this is where it is commonly called store and forward. The data is captured by the provider that is gathering the diagnostic data, and the exam is completed at a separate time or place. And the ADA provides a code for that as well, which is D9996. These codes should be closed out when the information is collected. So in most of the cases that we use, we call that the assessment appointment with the dental hygienist. Okay, so you would close these codes out then. The next is direct to consumer and live patient monitoring. You don't hear much about these in teledentistry because they're not covered. They don't have a code, and they're not covered by any insurances. And direct to consumer is a consultation between the patient and a provider, usually using a computer or a mobile device. So you've maybe got private insurance plans you've maybe dealt with where they offer these things where you could get live with a nurse practitioner or something. Well, that's direct to consumer. There's no provider on the patient's end that's gathering the data and giving that to the doctor. There's usually just a communication, no x-rays, no photography besides the mobile device. And this part of the industry, not just in teledentistry, is changing very rapidly, and the quality of the service can vary very greatly. Okay, that's called direct-to-consumer telehealth. Next is live patient monitoring, and that is the management of, usually used to do the management of chronic disease. And a lot of companies offer these things with wellness plans where people get Fitbits or step trackers to lower their premiums. A lot of hospitals, if someone leaves from surgery or some kind of condition, they give the patient a device that they wear, and it'll automatically send data to the physician and also to emergency responders. In dentistry, you could think of things like maybe smart toothbrushes in the future or toothbrushing apps. For both of these things, there's no code, and Oral-B already even has a smart toothbrush that can give data to your dental hygienist. I don't know of anybody using this, but that's kind of the way to think of live patient monitoring. So another category to think about in terminology is your data collection technology, and this can vary greatly. The key is that every program needs to evaluate what their needs are, what their capabilities are, and what their funding level is. So you can get some really nice stuff that costs a lot of money, or you could get some more practical things, and everywhere in between. There's the essential thing is a tooth charting, electronic tooth charting, thorough clinical notes. Those top two things get a lot of things done, and direct digital radiology, and using handheld things like a Nomad, intraoral X-ray sensors. If you're doing it from a satellite clinic, you maybe have access to your panoramic or a cone beam. Also, there is a potential use for digital scanning equipment, digital diagnostic equipment such as a Diagnodent or pulp tester, and then there's even oral cancer screening devices. All of these are possible tools that can be used to do teledentistry, but what it comes down to is, what does the doctor need to feel comfortable that they can do an exam? That's what determines the type of technology. So you have to have your doctor on board with the type of technology that you're using so they can comfortably close out an examination using the technology and the person trained to use the technology to convey that diagnostic data. Finally, the other half of that coin is the teledentistry software. So teledentistry is more of a method, and the technology used to implement that can vary greatly. At both programs that I've set up at Comtree and at my private practice, we just use the dental electronic health record, and then we use Dentrix, both Dentrix Enterprise at the health center and Dentrix G7 at my private practice, and we store everything inside of that. Now, you do usually need to create some workarounds around the images and such to store them in the way that the doctor can understand them and read them quickly. So these are the questions you need to ask. What's your electronic record? How are your images stored? How are they integrated with your software solution or not? Do you have physical servers or cloud servers? Can you remote in to services? Internet, do you use internet hotspots when you're gathering stuff? Do you have Wi-Fi? And also, are you using laptops or tablets? Okay, teledentistry in Missouri is covered under Missouri Medicaid. Medicaid will reimburse for exams, x-rays, cleanings while using teledentistry for children, pregnant women, and nursing homes. It'll also reimburse for new teledentistry codes D9995 and D9996. Missouri Health Insurance, there's also a Missouri Health Insurance mandate which says that private insurers, while they don't have to pay that for those new codes, they do have to recognize that an exam is an exam, whether it's in person or it's using telehealth. Okay, that's a parity law that we have. And Missouri Medicaid reimburses $14.60 for those two codes. So you do a teledentistry program, maybe you go do outreach at schools, you can use this code as well in addition. General supervision. So the way Missouri made teledentistry allowable in the State Practice Act was the dental board, after considering what the Missouri Dental Association recommended and the Dental Hygiene Association recommended, the way they decided to fix it was take the original definition of a patient of record and add to it. So you could see that first bullet is the original patient of record definition. It was a very easy, straightforward sentence. And to allow for teledentistry under general supervision, they added that giant run-on sentence at the end. A supervising dentist may delegate to a licensed dental hygienist the collection of information and measurements necessary for the dentist to perform an examination prior to the dentist performing the examination and evaluation, and does not need to be physically present when the information and measurements are collected. He spelled it out real clear there in that beautifully worded sentence. But that was a big moment, and it was greatly accepted by there was not a lot of discourse in coming up with that conclusion. Our dental board did not want to create a new level of supervision. That's the approach they took. As far as patient of record, this is a follow-up to my last presentation. Doing this presentation last time, people still wanted to know, in the Missouri rule, when the provider is at the originating site and sees the patient, they are creating the patient of record for the dentist at the distant site. So the hygienist is creating that patient of record for the dentist under general supervision. This has no relation to the dental public health setting. Dental hygienist in a dental public health setting. That is completely separate and does not have to do with this. And in order to do any preventive care outside of the diagnostic phase, an exam needs completed via teledentistry prior to the preventive phase. Okay, I'm going to kind of go through this quickly. There are some people on here that might be interested in advocacy, but I've got a few slides here showing the progression of our state and how we got to where we are now, both from the national point and then zooming into as we get closer to everything, starting with in 2010 when the virtual dental home model came in California. I presented to the dental board in 2014 after I'd been at the health center for a year, inquiring about the teledentistry. The MDA created an ad hoc committee I was a part of to help word the recommendations to the dental board. The telehealth bill was passed in 2016 that allowed for Medicaid to pay for telehealth, and it also spelled out that store and forward was an acceptable form of telehealth in Missouri. And also during this time, we were piloting different ways to collect data and learning how to set our system up for when teledentistry was finally able to be done. And in 2017, October, we got our first grant that we'll go over soon to go over the first pilot program. Okay, so briefly, if you're not sold on teledentistry, or you need to understand why it might make an impact for you or your program or your state, your needs might vary. They can be for temporary shortages of providers, geographic shortages in different regions of the state, rural areas, increasing access by location, increasing services for outreach programs, decreasing travel times for your patients, early interventions for prevention and diagnosis, some economic development maybe in rural areas, and lower costs with higher reimbursement. And these are all different things you can maybe take to springboard discussions on why you might consider doing teledentistry to investigate. And I'll give you a little context. So the ADA in 2000 released a study between 2006 and 2012 that showed that during that time period, there was a decrease by 7% in total dental visits in the United States. But the population went up 5% and the number of dentists went up 9%. So why was there a decrease in visits? What was going on? When they zoomed in and looked at that, they saw that in private dental offices, there was a 9% decrease in visits. But in federally qualified health centers, almost 74% increase in dental visits. And in hospitals, there was a 20% increase in dental visits. That is a major shift in showing that where resources are lined up is not meeting people where they need it. And it requires a hard look at the dental delivery system and figuring out what can we do to meet people, because we're obviously failing as a profession if there was a 20% increase in dental visits to emergency room over a 6-year period. So this model shows cost versus delivery of care, showing that if you do nothing, it costs the least. If you do hospital dentistry, it costs the most. Teledentistry fits a nice niche right between a very basic screening program and portable dentistry, where maybe the dentist has to actually come on site to do care at a school. This semester, I worked with two dental students, D4 students from the Missouri School of Dentistry and Oral Health. And we did a study of 44 visits at Comtree for children 18 and under. We took 20 visits from fixed clinics among 20 visits amongst the 3 different offices, fixed clinics, and 24 teledentistry visits. We were trying to understand the cost between a visit in the clinic and a visit doing teledentistry. We found that patient time in chair was around 50 minutes in the clinic amongst the average, and 37 minutes doing a teledentistry visit. We found that the teledentistry visit, the salary cost was about $2 more. And the supply cost for teledentistry was about $1 more. We also saw that the fixed cost for in the clinic was $132 versus $47 in a teledentistry visit. The total cost for an in-clinic visit is $162.22, while the teledentistry visit was $65.75 per visit. This included a 15% admin overhead calculated into it, and the calculations for fixed costs was taking the income statements from the previous year, 2018, and seeing how much of the services developed or produced were preventive or diagnostic visits. Some of the takeaways that we saw, and we just finished our preliminary analysis of this. The study was done, like I said, using income statements from 2018. One thing we noticed was that the reason the cost was more for teledentistry and supplies was that the teledentistry visit was more likely to have sealants applied at that first visit. And teledentistry visits took more of the dentist and hygienist time, but the overall visits were shorter. The largest factor was the overhead cost of having a fixed clinic. And we think that the fixed clinic could definitely do better by decreasing their appointment times and increasing the number of exams. I think one thing to take away is that a teledentistry exam eliminates waiting on the dentist. So you can get that patient in and do everything. And I'm a dentist, obviously, and if you ask any hygienists that work for me and the dental assistants, they're always waiting on the dentist because we're running 2 or 3 chairs, maybe 4. And so when you're not waiting on the dentist, the visit can go quicker and the cost can go down. And a word of wisdom is all we have to do is decide what to do with the time that's given with us. And I think that's the key with teledentistry, is that you're being more efficient with everyone's time. And the dentist can sit down on a scheduled time and catch up on all the teledentistry exams they may have, or fill in no-show times with that. That'd be even better. So here's some examples of teledentistry. At ComTrue, we started with our initial pilot program. It started in 2017, funded by the Missouri Foundation for Health, utilizing portable equipment. And we went to schools, one nursing home, 2 primary care offices, and a detention center. Through this program, we trained 12 of our dentists to do teledentistry, 6 hygienists. We went to 33 schools in total, plus the nursing home and the 2 primary care offices. We also utilized a grant and used it to integrate into our primary care office. So prior to getting the teledentistry grant, we had a integration grant, and we used teledentistry in this once it was permissible under the state statute. So we did 139 exams with the hygienist in the primary care office using a regular exam room, 1 to 2 days per week at the 2 offices. They had scheduled appointments with the hygienist, and that was how our adults got into the dental clinic for comprehensive care. They went to a primary care office for a hygiene appointment. We tried to, if they didn't have a primary care doctor, we were working with them to get primary care services. In many ways, it helped us out with getting patients who had pre-existing conditions access to primary care prior to dental treatment and getting med consults. And also, the oral health person at the hygienist at the office would do consults for the nurses and the doctors in the primary care office. If they had something strange, or a patient came in, they thought they were having pain with their sinuses and it was a toothache, we just converted them right into a dental visit. Here's some pictures of our portable stuff. We use one of those Ford Transits to carry our equipment with a ramp that goes up and down. At ComTree, in the between October 1st of 2017 and February of 2019, saw over 1,100 patients using teledentistry. There was an average of about 67.5 teledentistry visits each month in that time period. A little over half of them were Medicaid. At the health center, we saw commercial and uninsured patients at no cost to them for the children when we went to their schools. And that is charges for Medicaid for store and forward. So just using that code during that time, it allowed us to fund some of the equipment and things like that through a new code that is covered by Medicaid to help cover the cost of doing the store and forward and doing the data collection. Also, at my private practice, Greenleaf Dental Care, I started in 2018 by increasing my hours. So the goal was for the office to stay open when I was not there. And so when I go on conferences, like tomorrow, they'll be open. I'm speaking in Washington tomorrow to some dentists. I also had the flu about a month ago. I had to cancel my patients for treatment, but all 5 patients that were scheduled that day in the hygiene column were able to stay. We just called the patient, said, "Hey, doc's out for the day, but they could still see it. He could do a teledentistry exam." All of them were like, "Great, I don't have to change my plans." And so they were all able to be seen. We're estimating that it's about 20 extra hours per month in what would have been canceled appointments or canceled days, closed days, which is a 22% increase in our office hours. So Access Teledentistry, we've developed a 4-phase approach to delivering teledentistry. And the 4 areas that we concentrate on are care coordination, data collection, examination, and follow-up. So care coordination is like the glue that holds it all together. And the reason is because, well, you also got this structure around it all, which you have to set up the proper legal, regulatory, financial, operations, technology, and training that kind of gives you a framework for success. But as far as like the delivery of care part of it, care coordination is the glue that holds it together and allows for you to move through the processes of a teledentistry exam. And that includes doing social determinants of health, evaluating that for your patients, having a care coordinator or a hygienist that asks the patients what they're expecting and setting their expectations up so that you can seamlessly communicate what the patient is looking for, what's realistic for the patient, so that the doctor can create a teledentistry exam that fits the patient's needs. Because the doctor isn't able to have that conversation with the patient of what their goals are and what's affordable and all that kind of stuff. Then the other thing the care coordinator does is navigate the patient through referrals and med consults and keeping a track on all that stuff. Maybe it's navigating it because it's in a community clinic and you need to know, are we coming back to the community school to do the care, or does that patient need to come into the office? And then referrals out, if you need to help refer the patient out of your system into another office or a specialist. The next step is data collection. So this is what we call the teledentistry assessment, okay? And that starts with radiographs. We recommend any patient that doesn't have one gets a full mouth series on the first visit, okay? And they get a full mouth series of x-rays just like this. And with a full mouth series of x-rays, you can get to a very high level of knowing what's going on. A dentist is very well trained at looking at the x-rays and getting a high degree of symptoms in the x-rays and figuring out what to do next. But we like to train people on doing a full set of orthodontic photographs. And that gives the dentist a lay of the land. The dentist can see what is going on in the patient, how their occlusion is, the look and the aesthetics of everything, and help the dentist zoom in on problem areas. Okay, this is an example of what at Comtree, that last one was at my private practice. At Comtree, this is what a child's teledentistry exam screen would look like. The dentist would have the x-rays up. They could click on the x-rays, make them bigger, have a full ortho series that's labeled for the doctor, and the tooth chart that is indicated by the hygienist, started by the hygienist. Also, if it's an adult patient, you would need a perioprobe so that you can see which teeth are restorable. And you could properly diagnose the next perio treatment. So in the tooth charting, the hygienist catches the tooth chart up on which teeth are there, which restorations may be there, and then the dental hygienist charts in the record suspicious lesions, and we mark it in black, and the doctor adds and takes away from that based off of what they see in the images and the x-rays and the notes from the patient. The next phase, the third phase for access teledentistry is the examination phase. It includes review of the information, diagnosis, a treatment plan, and communication. And this is what the exam review usually looks like. Doctor gets to stay home and sit in their bathrobe. The diagnosis part is critical with the photos. So what we like to do is once she takes the full series of images, if there are teeth with problems, you can get the intraoral camera out at that point and take a close-up of the pictures that are having the issues so the doctor can see those close-up pictures. And this is using a mouthwatch camera in my private practice. Here's some zoomed in x-rays of the teeth that had issues. I actually added on this, a watch between 7 and 8 for next time for this patient, and that was not indicated in the suspicious lesions from the dental hygienist. And so you could see that in the tooth chart here. So I treatment planned. Sorry, everybody. I'll zoom back. I finished the treatment plan. Got the patient's treatment plan. I added watches on 7 and 8 with notes on there, and finished the treatment plan up. The thing that we recommend is tracking care coordination, because the thing about teledentistry is not everyone is in the same room or the same building as they'd be in a regular dental office. So you can't over communicate in teledentistry. So we have some suggested workarounds and workflows that can help enhance the communication for treatment planning and communication of sequencing the treatment plan. So at Country and at Greenleaf, we add in the sequencing of the visits. So you have 1, 2, 3 visit in this case. You have a preventive visit with a filling, and then all 3 of these are treatment planned to be seen with Tooth Titan, which is the outreach van. So we took the ADA's dental care coordination code, which is D9992, and we added subcodes that tell the care coordinator and the person at the front desk, if the patient calls, where their next visit is when you sequence it. So you might have some kids that need some simple fillings, maybe a fragment of a baby tooth that needs taken out, and you could do that at school if the dentist is coming to the school in a couple weeks. But maybe they need nitrous, or maybe they need a root canal. We don't do those things, or they need an adult tooth out. We don't do that at school. So you put in there in clinic, care coordination in clinic, so that when the person is calling that caregiver or the nurse or whoever, and they're talking about the patient's care, they know where to send the patient next. We also added things like to the specialist as codes in there to help layer in the communication. Oh, too fast. Here's a good example of how well you can communicate. This was the first week of us doing teledentistry, but I'd been working with this hygienist for 3 years before this. And the first thing I noticed when I opened this patient's tooth chart at the bottom right is that they were low risk for screening in the screening category, low caries risk, had a watch on L. So then I go to the x-ray and look at L, and it looks like there's an occlusal caries on the occlusal of L. I then go to the picture, and I've circled the picture of L, and it doesn't look like there's any problems. But then when I went to her note, it said number L has occlusal wear, smooth depression, not sticky with Explorer. I knew with confidence that there wasn't a cavity there, and that we've gone over that in 4 different places in this exam, so that we know that we've got this tooth covered on this one patient. And that's just an example of how good notes and good using the tooth chart, you could communicate effectively as a team. And that's what good calibration also can accomplish. This is just another example of the care coordination and using the codes. Here on the right side, I have a 4-visit treatment plan, and it shows that the first 2 visits can be done using portable. The next 2 need to be done in the clinic because they are crowns, and the first 2 are cleaning and a filling, and the next 2 are in the clinic. And this just also shows an example at the end of how to communicate what's next. So patient needs 4 appointments to finish treatment. Recall and fillings can be done on site at community center using portable equipment. No pre-med. Patient chooses crown. She needs to make an appointment in the office. And then you put the distance site, Greenleaf Dental Care, and then your location. In Missouri, you need to do that on all of your signatures, on all of your notes. Finally is the follow-up. It's important to have a system in place to prioritize urgency. Most of our teledentistry exams are done using store and forward, but there are cases where we had to get on a secure video conferencing software to do an urgent synchronous teledentistry examination. So we were able to get in, look at the patient, look at something on the computer screen, and get that patient an antibiotic, and maybe refer them for the extraction faster than it would normally take. Also, some patients need to be categorized into the recall for their follow-up, and then figure out what kind of treatment needs. You need to make sure a good program has the follow-up part covered. And care setting, if you have multiple different locations or you have mobile and portable or specialists, you need to evaluate the care setting. What kind of treatment follow-up is needed in different care settings? And this is an example of reports we would run at Comtree after visiting a school so that we could care coordinate those patients. Here's some examples of setup, pictures of our different setups at Comtree for follow-up. This is the last section that we're going to cover today, and it's different care settings and different use cases for how you could use teledentistry. And so for this, I'd like you just to think outside the box, and we're going to go through just some different possible ways to use teledentistry, from the common ones to the not so common. So the traditional teledentistry is done using a hygienist to go to schools and take support staff and doing portable equipment, loading and unloading, providing preventive dental care. And here's a little checklist of some things you might consider if you wanted to do a program like this. So this is school portable, we'll call it. Okay, another use case for teledentistry would be at a nursing home using portable. Now, how we did it a little different was we had a medical cart, like a nursing cart, that had our common supplies in it. So it had impression material and all the stuff for sleeves for the stuff, and we left that there. We just brought our laptop and our Nomad out, and Tiffany would go room to room for that to do teledentistry assessments in the patient's room. And then we'd schedule every other week a treatment day in a conference room, and we'd bring more equipment on those days, and we'd bring a wheelchair lift. So that was how we kind of set up our nursing home program. And that worked out really nice, having a cart there. You didn't have to lug as much stuff because it was always there, and you just refilled it as things got low. The next one to consider is mobile optimization. Okay, so if you have a mobile clinic, you could use teledentistry to enhance your mobile program. You can do a lot of mobile care programs. They'll go and they'll be at a school for a week or 2 weeks, and the first part of being at a school is just triaging patients. Well, using teledentistry, you could assess and do prevention through the first few days before the dentist even gets there. The dentist can do the triaging and the examinations from a different location, and the dentist only comes when they're needed for their surgical expertise. Okay, so say there's 100 kids. Maybe 40 kids the dentist doesn't even need to physically see. Maybe there's more than that. But it allows you to keep the dentist at the expensive clinic doing surgery as much as possible and doing examinations from a computer and during their downtime or during a scheduled time or even during no-shows, which we did a lot of at Comtree. Portable mobile hybrid. So say you also have a mobile clinic. And it's very busy. You've got a very busy schedule. You're always doing treatment. You can never finish treatment. Well, turn the mobile clinic into just treatment. Buy a portable program, a van, and some portable equipment, and send the portable unit out ahead of the mobile vehicle. So maybe you're 2 or 3 weeks before you go to a school, you're doing all the assessments, and the dentist is on the mobile unit doing the treatment following 2 or 3 weeks later. Or some combination of that. But that's just one theoretical way you could use teledentistry to enhance your program. Also, there is a couple ways you could do primary care. One would be without a dental hygienist at all. In Missouri, the dental board supervises dentists and dental support staff and dental hygienists. The dentist, as long as they can feel like they can create a patient relationship that meets all the standards of the dental board, and they can create a diagnosis and get the information they need, a nurse practitioner or a doctor could send them images and like a set of data that is predefined by the dentist through some sort of digital exchange to provide consultation to a medical provider. So I know of one program in Missouri that has a very pro oral health nurse practitioner, and they want to have a camera, and if they have a person that has some sort of suspicious lesion or a toothache, to take a picture of it with an intraoral camera and send it to the dentist. The dentist could do a limited exam with that and get the patient scheduled right through a video conference, or even call the patient the next day or later that day and give them the findings of the results of that. Okay, and that can close the gap. Instead of you schedule the patient at the dental clinic, maybe you can't facilitate that and the patient can't get there, you kind of cutting out that extra step of that visit so that they could get to care a little quicker. Another option is to do it with a dental hygienist. Have a dental hygienist as part of the medical team. The issue with these kinds of programs that are at a hospital or at a medical clinic that we learned is you need medical staff members that are oral health champions. If you don't have an oral health champion that is not a non-dental person, it is hard to succeed. And also that dental hygienist, if you do have a dental hygienist that goes, they need to be part and feel part of the medical team. They need to be all in, and they need to feel integrated into that medical team. But with a dental hygienist, you could do what we did at Comtree, where you have a dedicated room, or you have a cart, she goes room to room, and you do some things like that. But I would suggest in both scenarios there's a dedicated person that knows how to facilitate the care coordination and supports those extra visits, because no one wants an extra thing to do if you add a program. So you need the support person in both of those instances to facilitate the care coordination if the hygienist is not going to have the time or training to do that. Another one might be emergency room diversion. Hospitals could have a protocol, and I know a friend of mine worked as a resident at a GPR, and she said it would have been great if she could have done teledentistry before she got up at 2 a.m. and drove in and found out it was just a little toothache and they couldn't get it out until the clinic opened the next day anyways. So that patient was going to sit there until clinic opened the next day at the hospital, regardless of but they were required to come in at 2 a.m. So there are some ways to facilitate and get the dental data information exchange between the radiology department at the hospital or the ED. Then you could probably institute something like that. Another possible is just a general oral health person at a hospital. Maybe they have a cart and they could go to different departments even and facilitate that exchange of information between the pediatric department, maybe the OB department, and the cardiology department needs a consult, all that kind of stuff. Maybe there can be a way to facilitate that, but it's going to require contract with a dentist and figuring out a relationship with a dentist and hiring the right staff to send the information to them. Another way is just using it to extend your hours. So you can have at Greenleaf Dental Care, our biggest time that's booked out a month, sometimes more, is 5, 6, 7 o'clock appointments on Tuesdays. It's our late night. Patients love that. So maybe you can add, 2 days a month where you're open till 8 o'clock for more hygiene appointments. Patients might find that convenient and useful. Or even Saturdays. Also, dentist shortage problems. You could use teledentistry to cover during maternity leave, or when you're waiting for a new dentist to come on, or your contract with a dentist. You have to contract with a dentist to keep hygiene covered to maintain your current patient load, so that you're not losing patients and missing out and having to have people not be able to do anything. You can maintain hygiene at least and checkups by contracting with a dentist that could do teledentistry for your office. So when we were shorthanded at Comtree, one of our dentists left to move back to Hawaii. She's still licensed in Missouri. For 4 months, she was doing teledentistry exams in Missouri from Hawaii. So that's just one possible way for you to keep your patients being able to have access to care through hard times. And finally, the last part would be using specialist consultations. So you could alleviate transportation if you had a specialist, especially if you're in a rural area where patients have to drive far, with finding a specialist where the specialist can have that consultation in your office right then with the patient, and so they don't have to make that trip for the consultation. This is the origins of telemedicine, how this was started, doing consultations with urban centers. So this is a possible way. You have a oral surgeon that, or an orthodontist or an endodontist, and they're willing to figure out how to set this thing up. You can work with them on doing consultations, and then they can schedule the patient right then for their treatment. That's just another possible application for teledentistry, doing consultations. Finally, that's it. And if anybody has any questions, you can reach out to us through email. There's my phone number. We have a website, accessteledentistry.com, and then we also have a Facebook group that we just started to get people in, and we could start. It's called Mouth in the Cloud, where we're going to share our stories of how we're doing it, provide pictures of different things we're using, show cases of ways you could use this, and hopefully share ideas. That's the goal. So with that, we can go to questions.
So this is Gary. Actually, Tiffany has answered a couple of questions in chat. I'll leave that for you all to look at. But we have another question. I'm sorry if I missed this, but is a teledentistry exam done with a different code, or is there simply an additional code for billing?
Can you repeat that? Okay, here, I see the question.
Sure.
No, so Nicholas, you can do the exam real time if you want to. That's called synchronous teledentistry, or you could do it at a separate time, a separate place if your state allows it. In Missouri, you can. It's called asynchronous. There's 2 different codes for that in the ADA, and that's how that works. I hope that answers that question.
Great.
Any other questions?
It does not look like there are other questions in chat, and we're coming up on the last minute. Wait a minute. Are there any payers who prohibit this?
So in Missouri, there's a law that's saying they don't have to pay for that code, that uncovered code. Medicaid is covered in Missouri, and some states, those new codes are covered. But if your state has a parity law, they have to honor the visit, whether it's in person or through telehealth. Missouri has that. I know Washington also has that parity.
All right. Last call for questions. You have a thank you for a good presentation in chat. And
Nicholas also asked if there's a separate code. There is a code. Say it's an insurance company and they don't take the new code. You still are able to bill out the exam and the x-rays just like you would normally do. Okay, you cannot do a prophy in Missouri if they haven't been seen for an exam in a year. So if the patient's been seen in a year, they could do, if it's a recall, they could do their cleaning that day with their teledentistry exam. But the additional code still needs to be closed out to code correctly, but they won't pay. Private insurances will not pay for that code. And Missouri Medicaid pays for it.
All right, we're at 101, being cognizant of everyone's time. I want to thank you all for attending. There will be a recording available later. It'll take us a little bit while to deal with the technical issue. Mary, we do have one other question. You got time to take it, Dr. Suter? Sounds like not.
I've got time to answer questions. So if anybody wants to stay around, they can answer.
Okay, there is another question. Please
Mary,
expound. Go ahead.
Mary, there is Missouri nurse practitioners. So a nurse practitioner could send a dentist information. They'd have to have meetings and and figure out what was needed for the dentist and some agreements written to do it. But a nurse practitioner could send the dentist information to do a teledentistry exam if the dentist gets the adequate information to do it. The case that I'm aware of in Missouri where they're trying to do that, it's for mostly like limited exams. Like, hey, I have this thing, can I get a consult or a limited exam? And then there'll be some communication with the patient. And some that could be live if the dentist had the time to pop on there, or it could be asynchronous as well. Katie, you do build asynchronous code at the time of the data collection, and the exam code is done when the dentist performs it. Yeah, we actually recommend that the X-rays get closed out with the dentist as well, because technically you're billing for the review of the X-ray, not the taking of the X-ray. If you look at the definition of dental radiographs in the coding.
All right. I think we have exhausted the questions. So again, thank you all for attending. There will be a recording available. And thank you very much, Dr. Suter. It was an excellent presentation. And I see Julie has noted that this is inspiring and says thank you. I agree. I think teledentistry is inspiring and will definitely help, as I said at the beginning, with access issues in Missouri as we develop the system and practitioners become used to working this way. So thank you all very much. Have a great afternoon, and we will talk to you soon. Bye-bye.